So palpitations is a term that people often use when they are aware of their heartbeat. It does not necessarily need to be fast, but it clearly is disconcerting. And this can be due to various reasons. And that's why we need to often do a period of prolonged ECG monitoring to find out what your symptoms are due to. So as we get older, the kinds of arrhythmias we're prone to tend to vary. Atrial fibrillation is a very common arrhythmia that we find in older people, and this would often be sensed as an irregular heartbeat. People wear a lot of wearable devices these days, Samsung watches, Garmin watches, Apple watches. They're all very good at detecting atrial fibrillation. So if ever your watch or your wearable device picks this up, do not ignore it, because we need to look into potential risks that could be associated and whether you need any additional form of treatment. So catheter ablation is again something that we would recommend for people who are otherwise well, who have atrial fibrillation. We quote success rates as high as 70 to 75%, but this would vary from person to person. So it's important to come and have that chat about what the best treatment option for you is. So when we do a catheter ablation, essentially we get access to your heart by putting sheets in your groin. We put wires up to your heart. And depending on what your palpitations are due to, so depending on what the kind of arrhythmia is, the area of interest would differ. And we spend a lot of time working out the precise spot that we need to be interested in, because we absolutely cannot afford to get it wrong. And once we are confident about where this particular rhythm is arising from, we would then potentially cauterize that area. Again, we have different technologies available. We can use the freeze technology, we can use pulse field ablation, radiofrequency ablation, but essentially we prevent the area of interest from being able to take part in an abnormal heart rhythm in future. Very occasionally these areas can recover over time, and if that's the case, then we go back and target that area again on a later date. When you experience an abnormal heart rhythm, it's often due to a very clear circuit within the heart. And my job as an electrophysiologist is to try and work out where that circuit is. And by having wires in your heart and potentially putting your heart into an abnormal rhythm in a very controlled environment, I can then, with a great degree of accuracy, predict which bit of your heart is causing the problem. I will then be looking to scar that area using the different technologies that are available, and that will hopefully then prevent you from having the same rhythm problem in future. There are different ablation options available. The most commonly used one, which has also been around for many, many years, is radiofrequency ablation, where we can be very precise about where we are burning. It's very useful for all the different arrhythmias out there, whether you have an SVT or atrial fibrillation or ventricular tachycardia, we know that radiofrequency works very well. If your arrhythmia, for example, is atrial fibrillation, and we are looking to do a procedure under sedation, a very effective way of ablating this is using the freeze technology or the cryoballoon, because we know it is quick, it is tolerated very well with sedation, and it's very effective with results very similar to all the other technologies. With regards to pulse field ablation, which we use not just for atrial fibrillation, but we're increasingly using it for different other arrhythmias, the slight limitation we have at the moment is the need for general anesthesia. So if we have access to general anesthesia, this may very well be an option for you. So risks for ablations vary depending on what the underlying problem is. So for a simple ablation where we are treating what we call a supraventricular tachycardia or SVT, risks are very minimal. I would normally say about 1 in 1,000 for a major complication. When we do an AF ablation, the risks are a bit more because we have to go to the left side of the heart, and the risks then would be in the range of 1 in 100. When we talk about ventricular tachycardia ablations, these are the most complex ablations we do, and often people who need them are otherwise quite unwell, and the risks are significantly more, in the range of 1 to 5% potentially for a major complication. Recovery time is again dependent on what kind of ablation you've had, but generally I would say a week would seem reasonable after an AF ablation. Legally, you can be back to driving 2 days after an AF ablation or an SVT ablation, but we generally would recommend at least a week to 10 days of rest. So catheter ablation is a very effective way of treating arrhythmias, especially if you've been suffering with symptoms for a very long time or you haven't been coping with tablets. This may well be the solution for you and may potentially fix the problem completely. There are risks involved like any invasive procedure, but often the benefits well outweigh the risks, and that's why we would recommend a catheter ablation.